70-year-old male. When we arrived, he was complaining of chest pain, dizziness, and syncope and heart palpitations. So he has no allergies to any drugs. He's on silazepam and aspirin. He has a history of having an MI 5 years ago. He's now unable to obey commands, and from his vital signs, he's severely compromised. So he's got a blood pressure of 70/40, a heart rate of 170, and he is in VT. He does have a pulse in his carotid up here, but no distal pulses. So that's because he is in VT there. Just silence that. So I've gained large bore bilateral IV access, and I'm now going to run a bag of fluids through as a fast bolus in an attempt to raise that low blood pressure. We've placed his O2 mask on him with a reservoir set at 10 litres per minute. I've gained bilateral large bore IV access. We have the blood pressure cuff in place, and we have a 3-lead ECG in place. As he is severely compromised, cardioversion is indicated. So Sophie, would I please be able to get you to call for R50 backup, and because he has the potential to deteriorate. While she does that, I'm just going to go through the preparation of cardioversion. So I'm going to attach the defib pads.
They're 2 minutes away.
Great. And I have the bag valve mask here ready as well with an OPA in case he does go into cardiac arrest, which is quite likely. So I'm applying these. Our defib is on manual mode. Selecting the lead with a visible R wave, because that's lead 2. I'm now going to sync. And confirming, I can see it on the monitor here. I'm just going to print that out to confirm that I can see
Check patient.
That I can see a detection symbol above every R wave. So as you can see, there is a detection symbol above every R wave. But it is safe to cut over, and he is in VT, as it is wide QRSs. So before I actually deliver the shock, I'm just going to go through the cardioversion checklist. So we've got the pads placed on either side of the sternum. Defib is in manual mode. We've selected the most visible R wave, and there is no artifact. It is in synchronized mode. There is a detection symbol above every QRS. The patient does not require sedation as he is unable to obey commands. The joules are set to maximum joules of 360. So I'm now going to charge. Checking that everyone's clear. Sophie, stay clear of the patient. Now, delivering a charge, everyone clear. Delivering charge. Shock delivered. So now I'm going to redetermine the rhythm. So I'll do another print here.
Check patient.
And as you can see, he is still in VT of a rate of 160 to 170. So we can deliver a second shock. Well, first we need to resynchronize. Print that out again to ensure again that we do have the detection symbol above every QRS complex. And yes, we do. So again, he is safe to synchronize again. He's still in VT. Okay, so now charging up the defib. He does not require any more sedation as he is still, again, unable to obey commands. So I'm going to deliver a shock. Everyone stand clear. Holding the shock button. And the shock has been delivered. So again, reassessing the ECG here. So we can print that out again. And it's looking like he's gone into sinus rhythm. And his heart rate is coming down to 94. So no more shocks will be delivered. Thank you, Sophie. It can be difficult to differentiate between VT and SVT, But in VT, the ventricular rate is usually over 150 beats per minute. The rhythm is broad complex, so the duration of the QRS should be over 0.12 seconds, and VT is usually associated with cardiovascular compromise. All of these signs are present, so it's safe to assume that Peter is in VT. It can be difficult to differentiate FVT with abnormal conduction from VT. However, it should be treated as VT if there is any uncertainty. VT is also more likely if the patient is older, has ischemic heart disease, or is compromised, all of which are present in Peter. Although no ECG interpretation method is completely accurate in differentiating the two, if the QRS complexes and the precordial leads are concordant, so all either negative or positive, then it is more likely to be VT. And if the QRS complexes have a long duration, and if there is right axis deviation, it is also more likely to be VT.